All right, let's get started. Good afternoon to most of you. Welcome back to the Medical Biochemical Genetics Clinical Course Seminar Series. It's September 23rd, 2022. This is week 10 of the series, and we're fortunate again to have Dr. Arig Gharbawy from Duke come to talk to us about more carbohydrate metabolism. So just a couple quick things, as always. Make sure you remain on mute. You can discuss things through the chat if you want, and questions can probably be saved to the end, but if anything pressing comes up, I'll let Dr. Gharbawy know. CME credit is offered and will be coming up. The code will be coming up in the chat too midway through the discussion. And just a preview of the next couple weeks, we've got mitochondrial metabolism coming up next week and the week after with Drs. Marnie Falk, and Austin Larson. So with that, I'm getting handed over to Arig.
So can you see my screen okay? And you hear me okay?
Yep.
All right, so I'm not going to be able to see any hand raises or anything, but yes, if there's something that I should stop and repeat or do, please let me know.
I will. Thanks.
Yeah, thank you so much. So this is part 2 of the carbohydrate metabolism, and just let me see if it's advancing my slides. So today I'm actually going to cover a topic that we don't talk about too much, and that's the glucose transporters, since it's still part of the carbohydrate disorders. I'm going to talk only about the common ones that we see. I mean, there are much more than 3 or 4 disorders, but those are the ones that I chose. Pyruvate metabolism, fructose metabolism, galactose metabolism, and the pentose phosphate or the transaldolase, the condition that we kind of hear about from time to time. And we have testing for it, but we don't see it as often. So last time we spoke about the glycogenolysis and the glycogenesis disorders in GSD1, and we kind of hit on some of the glycogenolysis, glycolysis pathways that are associated with the muscle disorders of GSD, as well as the different types of GSD based on the new classification that I had in tables from last time. And this time we're just going to go to what relates at the end of the glycolysis, so pyruvate metabolism and where it goes to through Krebs cycle, as well as the pentose phosphate shunt, and then other gluconeogenesis disorders which involve the fructose metabolism as well. So we know that carbohydrates vary in their composition and types and shapes and forms. So mainly, just to remind you that in adults, usually the constituents of the carbohydrates in the diets are mainly of starches. If I could say that, about 60% at least are starches, but also, of course, they ingest simple sugars, and that's counted too. However, in the newborns and the young infants, it's the primary carbohydrate is mainly galactose and fructose, and things that if they give them something that has sugar juice or added sugar, it's sucrose. And that needs to be absorbed. And that's where the transporters come in. So the intestinal transporters, at least, and some have intestinal, proximal, renal, as well as hepatic. But just to give you an idea about the intestinal here. So you have the starches have to go through alpha amylase, and then that will change into simple sugar, glucose, by passing through steps of digestion in the intestine. So you can see maltose, maltotriose, isomaltose, and alpha limit dextrans. They all change at the end of the day to glucose. And based on the disorder and where the malabsorption is it galactose? Is it glucose? Is it fructose? Is it maltose? You have to kind of limit the primary carbohydrate or that is causing the problem. And then you have lactose, which is a disaccharide that changes into glucose and galactose, and that needs lactase to be there in order to do that. And then you have sucrose that needs sucrase to change also into the simple sugar form. And I just want to explain that each one of them can have a genetic cause or an acquired cause. So patients who have, for example, diarrhea for long periods of time can have secondary lactase deficiency, not a primary genetic one. and so forth. So the disaccharides get split by the intestinal enzymes, and from there on, they change into glucose primarily, but other sugars as well, based on, again, if it's a disaccharide. And if you have a defective breakdown in the pathway, absorption, is defective, and it leads to flatulence, bloating, abdominal cramps, and diarrhea. For an adult, they're troubling symptoms and signs, but for a baby, it can be, very devastating, because they'll develop dehydration easily. It'll be very difficult to feed them, and they can have perianal irritation and ulceration and so forth. So one of the conditions that you may have heard of is the sucrase isomaltase deficiency. And I chose that one because it has a treatment. And I actually got to know about this recently. So this is an autosomal recessive condition, and it's associated with sucrase isomaltase deficiency. The manifestations, of course, are more in the younger children and depend on the amount of ingested sucrose and sweetened foods. So that's important to remember. It's caused by genetic variants in the sucrose isomaltase gene, and there are 4 common variants, mainly related to the sucrase domain, and then there's one variant that's associated with isomaltase. So the new thing about this, or the thing that was new to me, is there's enzyme replacement therapy for this condition, and it's called saccharoside. It's an oral solution, not an injection, and the trade name is Sucrade, and it's it's part of the dietary regimen for these children, as well as limiting the sucrose intake in their diet. And then there's glucose-galactose malabsorption, rare conditions again, but in these patients, the intestinal disaccharide activities are normal. Fructose can be absorbed normally, but they have problems with glucose and galactose. And of course, when you think about these, okay, where the problem is just avoid the galactose and anything that has free sugar in it as a glucose form. So these are patients where you don't want to give glucose as it is for them to absorb it. But the idea is you have to know them, because these patients will develop very diffuse watery diarrhea with dehydration. Some characteristics of it, of course, we don't have that abnormal breath hydrogen test, as readily available in clinics, but they can have, a large amount of glucose in their stools, and reducing sugars, generally, if you check that in the stools, so more than 2 grams. So there's is a malabsorption diarrhea that has an osmotic component to it, and it's important to remember that one. And then the diagnosis is confirmed by finding mutations in the SGLT1 gene, which is a sodium glucose cotransporter, or what we call symporter. So it's one of the SGLT transporter like defects. And then the diarrhea stops when you give the infant or the neonate free, a diet that you remove free glucose and galactose from. So it's important. So you would choose a formula that has fructose, but not sucrose, or limited amount of fructose, let me put it that way, because fructose still changes into glucose. But you're going to have to find something that does not break down into glucose and galactose. So anything containing sucrose is not a good idea here. And then glucose transport defects. So I'm sure you've heard about GLUT1 deficiency, which is considered, one of these conditions that we will diagnose, but the primary treatment comes from the neurologist's end. And usually they see these cases more than genetics or metabolic does, but it is one of the conditions of the 2 that we usually will give a ketogenic diet for. So GLUT1 as well as pyruvate dehydrogenase deficiency are, 2 of the common conditions. They're not common in themselves, but common conditions associated with a ketogenic diet in our world. So GLUT1 deficiency is mainly autosomal dominant, and there's usually de novo genetic variants, but it can be rarely autosomal recessive, and they will, present much earlier. The manifestations are seizures that are severe to treat, developmental delay. They can have microcephaly, they can have spasticity, and they've expanded the phenotype, so you can see a movement disorder that's associated with this condition, as well as absent seizures. So the type of the seizures are variable as well, the spectrum of that. And then they can have cognitive impairment from simple learning disabilities to more significant forms of intellectual delay and so forth. The diagnostic suspicion, and what usually gives it away, is the CSF glucose levels compared to the blood glucose, and they also have low CSF lactate. So what's happening is the glucose in the CSF usually is lesser than 40 in that range, and it's much lesser than compared to the blood. And when you look at the ratio of the CSF to blood glucose, it's if you see the ranges between 0.65 to 0.1 in some of the publications. So for example, a 0.41 level would give it away. The mutation testing, which confirms the diagnosis, is in the SLC, so it's a solute carrier transporter defect, also known as GLUT1, and it's located on chromosome 1p342. And again, the treatment is mainly a ketogenic diet. If you want to know more about it, this is a reference that takes you to the state-of-the-art 2020 recommendations and so forth. For glucose transporters, another defect that I may have mentioned last time is Fanconi-Bickel syndrome, and this is one that was originally classified as GSD, or glycogen storage disease type 11, but it is not a glycogen storage disease. It's a transporter defect. It affects the intestinal absorption as well as proximal renal, and those are the main things for the glucose and galactose reabsorption. So these patients will develop liver deposition of glucose or glycogen, but it's secondary to the transporter defect. They also will develop severe renal tubular acidosis with accumulation of in the urine, or loss of in the urine, phosphorus, so they can develop rickets as well as calcium. And these are patients that usually are treated hand in hand between genetics, endocrine, and renal, for making sure that they get all the supplements that they need to maintain their ability to grow and so forth. And even in patients with severe disease, they can come back to being able to ambulate. Some of these patients have severe proximal myopathy and so forth, once you supplement them the right way they should. And the supplements will include electrolytes, phosphorus, calcium, and carnitine, because they lose carnitine as well. The diet includes that's as much as possible free of galactose, but they can receive glucose IV infusion, so IV is fine, and we do use that at times when they're in the hospital for procedures and so forth. They can receive fructose, so that's fine as well. They have no problem with that. And then there's another condition that I found kind of interesting. So GLUT10, which is another solute carrier gene, it's actually not a glucose transporter. In fact, it's a mitotransporter for the oxidized form of vitamin C. And loss of that GLUT10 function causes arterial tortuosity syndrome. And this is an autosomal recessive disorder condition characterized by tortuosity, elongation, stenosis, and aneurysm formation. And there's more, I guess, that we'll know about these conditions as we get to keep them in mind and hear about them. And then I'm going to move through pyruvate metabolism. So, pyruvate is the end product that happens from glycolysis. And just to remind you of the picture here, so if you look at glycolysis, down here comes pyruvate, and pyruvate comes from multiple sources. So it comes from lactate, because there's between lactate dehydrogenase. So here it comes from lactate, between lactate dehydrogenase, and then it comes from alanine metabolism, as well as from, as I said, the end of glycolysis. I think there's an echo. Not sure why.
I don't hear it.
You don't hear it? I hear an echo. Sorry about that. Okay, so pyruvate, the metabolites related to pyruvate. What happens is, so it will go into metabolism by breaking down into, it changes into acetyl, and then pyruvate will change into either oxaloacetate, and this is going to happen through pyruvate carboxylase, or into acetyl-CoA, and that will happen through pyruvate dehydrogenase. But for pyruvate to go down into the mitochondria to cause these effects, you need to have a mitopyruvate carrier, which is that MPC. And then in the mitomatrix, pyruvate is converted to acetyl-CoA or oxaloacetate. If you think about it, these are both important for oxaloacetate enters the CAC for anaplerosis, or replenishing the substrates that go into the Krebs cycle, and then or is converted to phosphoenolpyruvate for gluconeogenesis. So again, it's important for gluconeogenesis. And then this phosphoenolpyruvate here can be formed from oxaloacetate by PEPCK within the mitochondria or within the cytoplasm. I'm just going to say there are deficiencies associated with PEPCK, and you have to, when you confront them, see, is it mitochondrial or cytosolic? They're very rare, but there are some patients with hypoglycemia that can be associated with it. And I'll tell you now, it might get picked up by chance on whole exome sequencing and so forth. So just giving you an idea of where it's coming from. These are conditions that are very rare, but come up sometimes in patients when you do whole exome sequencing. It's important to know the enzymes that are associated with pyruvate metabolism, because we know some and we see them more frequently than others. And there are a bunch of them. So the ones that we're going to go into details is pyruvate dehydrogenase and carboxylase. But you do know from, just the glycolysis pathway and glycogen-associated disorders that there's a lactate dehydrogenase within that pathway. And these are the patients who will have myoglobinuria and so forth. And then there's a pyruvate kinase, and those are the patients that have hemolytic anemia and hyperbilirubinemia. There's an ALT, which is also called SGPT 1 and 2. The SGPT1 is very mild and the defect is unknown. The SGPT2 is associated with some changes that are associated with neurodegeneration in the brain, and probably you'll hear about them over time. And then there's the mitochondrial pyruvate carrier that I spoke about that needs moves the pyruvate into the mitochondria for metabolism. And these also are rare conditions, very rare conditions. Actually, you can see 2 cases and so forth. You can see the incidence here in the table, how rare they are. But just to give you an idea about where pyruvate metabolism is moving for when it comes to conditions associated with the pathway. And PDH complex contains 3 enzymes. The E1 is the one that we see most of the time. So that's the one. So that's an alpha-2-B2 heterotetramer, and it's associated with the irreversible oxidative decarboxylation of pyruvate to acetyl-CoA. And that's important because, again, pyruvate metabolism is associated with glucose carbon generation, or glucose and carbon generation for the TCA cycle. So it's so important to remember that part. And then it is the one that's associated with the most common form, which is the X-linked form associated with the E1 alpha gene. And this is, despite X-linked, you can see it in males and females. It's a brain mainly phenotype. So it's important to keep an idea in your mind that both males and females could be affected severely in this condition. And then we have the E2, which is the dihydrolipol transacetylase. And that forms the structural core and accepts the acetyl group. And for that, is the coenzyme A is considered a cofactor. So I just wanted to say that table that came up first. So we have 3 enzymes associated with the pyruvate dehydrogenase pathway and 5 cofactors. And these cofactors are coming from the different cofactors that are associated with the different enzymes associated with the subunits of the main complex. Okay, so E3, or the dihydrolipidol dehydrogenase, is the third part of the complex, and it's also associated with cofactors. And you can see here in the table that the E1, which is the pyruvate dehydrogenase, the cofactor is mainly thiamine. Now, do patients usually respond to thiamine? Not really. We haven't seen too many that do. But then these are things to use if there's lactic acidosis and so forth, just to make sure that you've used whatever can make a difference in these patients. So it's important to still add thiamine and see if it has an effect. For the E2, the dihydrolipomyl transacetylase enzyme, you use pantothenic acid, which is coenzyme A basically, and lipoic acid. And then for the dihydrolipomyl dehydrogenase, it's B2 or riboflavin, and NAD if that is available. Okay, and then we have the E3 binding protein, which is in between those subunits. And as I said, it requires these 5 different cofactors for the subunits to work. For pyruvate dehydrogenase deficiency in general, the clinical spectrum of this condition is very broad. The X-linked form is on the short arm of the chromosome. One of the things that you need to know is that it is associated, the spectrum, with the onset of presentation. So the neonatal onset is the most severe form, and that can be at times lethal. And then we have the infantile form, and then we have the late onset form for the adults. So based on the age of presentation, the severity of the disease kind of correlates, but not with the mutations themselves. So interesting enough, this is one of these conditions where the genotype does not predict the phenotype. And that's important to remember too, because sometimes you would think that a missense mutation is less relevant than, for example, an insertion that causes a frame shift. It doesn't matter in these conditions. So it's one to just keep in mind. You have to look at the onset of when the disease showed and what the features are in the patient in terms of Lee syndrome or any of the findings that are usually presenting or they're presenting with it. So these patients can have severe lethargy, poor feeding, tachypnea, seizures, and then they'll have gray matter degeneration. And you can see the picture of Lee syndrome. It's very sad. The MRI reader for patients who have severe episodes will come up and say, oh, this is a very sad MRI. And basically, it seems that the brain has this necrotizing encephalopathy with infarcts all over the place. And if you do MRS for these patients, you're going to see lactate peaks corresponding to these different areas where the stroke-like episodes are. So that can kind of give it away at times as well. They also can have agenesis of the corpus callosum, and that can be one of the disorders where if you see that, for example, they had imaging before, like prenatally, or had an ultrasound or imaging, and you see corpus callosal agenesis as well as features of seizures and lactic acidosis, you put them together and you would think about pyruvate dehydrogenase. And why am I saying that? Is because, again, this is our main condition that we don't give glucose in. So you have to be careful, when they come to you and say, okay, there's this patient who has lactic acidosis, corpus callosum, agenesis, and seizures. That's the patient that you want to be careful. We treat many of our disorders with a glucose infusion. This is one that you want to be careful not to. Okay, and one of the situations here is these patients, because of lack of the acetyl-CoA production, can't actually form ketones. Now, in a neonate, you usually don't have ketones, but in general, this is a condition where you're not going to have ketones. Just in general, you can't make them unless you give it to them through a ketogenic diet. They have severe hypotonia, they have weakness, they have spasticity, they can have microcephaly, they can have features that look like fetal alcohol syndrome, so that thin upper lip and a long philtrum and so forth. They can have developmental nonspecific signs like mental delays, they can have growth retardation. And a reminder for the neonatal type is that the seizures are very significant and are very difficult to treat unless you put them on a ketogenic diet. For the late onset PDH deficiency, the problems is these patients, you have to have a suspicion towards it. So in a patient who develops recurrence, so I'm talking about intermittent acute neurological symptoms, and they'll give it to you. They say, I ate a lot of candy, or I ate cake, or I ate something where there's a lot of carbohydrates, and then I had problems. You know, they either become ataxic, or they develop dystonia, abnormal movements, or they have episodic peripheral weakness. In your mind, you should immediately say, if they have any of these extrapyramidal disorders, recurrent, and it's recurrent. The clue is recurrent and intermittent. And the point is, ask immediately, what did you have? Did anything trigger this? And what did you have for food? What did you have for a snack beforehand? And then you would check the blood and the CSF lactate in between. They may be normal, so you want to check it at the time when they're having these episodes. Their cognition may be normal. They may be normal in between these episodes totally, so you won't pick them up during that time. But you'll pick them up if you do mutation testing, and you'll definitely, in that case, if they're having repeated episodes, you can prevent them by decreasing the carbohydrates, giving them some kind of modified ketogenic diet, and treating them with thiamine. For the E2 deficiency, and I'm going to talk about the diagnosis at the end and the treatment at the end, so I'm just going through all of the types. For mutations in the E2 deficiencies that are associated with the dihydrolipomide acetyltransferase, again, a recessive condition, not X-linked, this time autosomal recessive, and consanguinity is commonly reported. It's extremely rare. The interesting thing about these patients, so again, they present later in childhood, so not as early as the other patients with the X-linked form. Movement disorders are common. They can have seizures. They can have hypotonia that is very significant. But when you do imaging for them, the MRI can have features that look like pantothenate kinase associated neurodegeneration, which is associated with the iron deposition disease, so PCAN. And those are the so-called eye of the tiger lesions. They also can have problems with lactate. Sometimes I'm not going to say that it's usual, but again, it's the rare thing that you would find lactate elevated. Most of the time, it's usually normal. They can have hyperammonemia and non-specific amino acid elevations associated with the disease. Again, if you're going to pick up any of those, you'll find them during acute illness, not when they're okay. And then the treatment, because the cofactor is associated with lipoic acid, trilipoic acid and thiamine, or a ketogenic diet if it's really severe. Sorry. I just wanted to show you where the tiger eye is. So you can see here on the FLAIR images, I'm not a radiologist, but you can see that there's hyperintensity associated with hypointensity based on, again, the imaging here. The E3 deficiency is one that's associated with two other enzymes, the alpha keto dehydrogenase, as well as the branch chain keto acid dehydrogenase, which is associated with MSUD. So these are patients that typically can present with Lee syndrome-like. However, there are milder variants described, and they don't respond well to treatment. Just to keep in mind, I mean, because those patients, this latter group has an association with the branch chain keto dehydrogenase, you can assume, or you can actually detect if you do the testing, branch chain amino acid changes associated with the condition. So the confirmation of any of these diagnoses is by mutation testing, including deletion duplication testing or enzyme testing in fibroblasts if you have a variant and you're not sure and you want to make sure about the functional abnormality. But there was also used to be done at Case Western Reserve, as they would do testing to delineate the enzymes involved in the pyruvate metabolism pathway. So this is one of the ways to do it. but it is invasive because it requires a skin biopsy. You can also detect lactate and pyruvate in the blood. And this is the one where you have to take the lactate paired with the pyruvate, and it has to be drawn in the appropriate way and time, and look at the lactate to pyruvate ratio. And again, depending on what condition you're seeing, so in mitochondrial conditions, usually the lactate is more than the pyruvate. In these conditions, the problem is metabolism involving the pyruvate pathway. So pyruvate might be elevated, so that ratio will be low. The lactate to pyruvate ratio is only diagnostically useful, and that's very important, is if you have lactic acidosis. So if you see a lactate to pyruvate ratio that is abnormal, but there's no lactic acidosis, then you can't think of it as being a form of congenital lactic acidosis or pyruvate dehydrogenase. And why am I saying that? Because again, PDH is one of those where you have to make a decision about glucose infusion. So you're trying to get as much information put together to say, okay, let's limit the glucose intake for this patient. You also can see elevated alanine in the presence of elevated lactate. If you're checking plasma amino acids, you can see an E2 deficiency, high non-specific serum amino acids, and sometimes hyperammonemia in the acute crisis. If E3 is deficient, you can see the high branch the high branch chain amino acids, as well as alpha ketoglutarate in the serum and in the urine organic acids. And lactic acidosis, when it's there, it's an important sign, but in some of these intermittent forms, you might not see it. Again, elevated branch chain amino acids, when are there, it's important, and you can see MSUD-like metabolites in the urine organic acids. This is, in general, again, a way to look at pyruvate dehydrogenase metabolism and the effect of treatments. Okay, PDH itself is associated with deficiency. It's inability of the pyruvate to change to acetyl-CoA, which is important for, again, causing many of the substrates to be repleted. So if you don't have that, you're going to give an alternate source of energy, because glucose metabolism, remember, is going to be dangerous in these patients and will end up changing into pyruvate and no change into acetyl-CoA. So what you're doing is you're providing a ketogenic diet, and what the ketogenic diet does is allows for acetyl-CoA to be formed, and that will help in providing energy for the substrates that are in the Krebs cycle. At the same time, and for the brain, that's the most important thing, is that if the brain doesn't have glucose, the next thing that it can use is ketones. The other thing is dichloroacetate, and dichloroacetate is still continues to be under clinical trials, and then thiamine, because that's a cofactor, and then lipoic acid, because it's a cofactor for one of the subunits. The thiamine, carnitine, and lipoic acid can be used. Carnitine is used mainly because there's conjugation with acid production, the lactate, and so forth, and it gets lost in these patients. So you can have a secondary carnitine deficiency, actually more when you even add the ketogenic diet. So it's important to supplement the ketogenic diet with carnitine to make sure that they're not deficient. And then thiamine responsive cases are very rare, but you should think about it or consider it in patients who are diagnosed more than 1 year old of age. And in that case, they require high doses of thiamine. So next, pyruvate carboxylase. So that's the first step in gluconeogenesis. And pyruvate carboxylase is one of those conditions where, again, you have to keep in mind, it doesn't have a problem with giving a glucose infusion. So it is the reverse of pyruvate dehydrogenase in that aspect. It's important because it's the first enzyme that kind of promotes gluconeogenesis, if I could say that, and catalyzes the step of pyruvate changing into oxaloacetate, which is important, again, for gluconeogenesis. So one of the things that it plays the main role in is anapyrosis again, which is repleting the substrates coming from oxaloacetate, which changes into citrate. So again, repleting the substrates that fill in the TCA cycle for energy. And then at the same time, it's one of those enzymes that are associated with gluconeogenesis. If you recall, the carboxylases depend on biotin as a cofactor. So this is one of them, one of the carboxylases that uses biotin as a cofactor. It's tissue specific in this case. Liver, pancreas, brain, and adipocytes use it very much. And then it controls, again, it's very important, the pyruvate carboxylase. When I say the pyruvate carboxylase is tissue specific, the pathway in the brain, the pathway in the liver, and so forth, each one of them has functions of their own. And you can see in the liver metabolism how important it is. So it's associated with different pathways in its own self. And then it's also associated with the redox potential from the substrate oxidation factors that are coming from the tricarboxylic acid cycle. So a very important enzyme. The clinical spectrum is broad, from mild to severe disease. The milder forms are ones that might be picked up by chance and will respond. I guess if I could say to triheptanoin, since they've been using that for those patients, as well as other anaplerotic therapies. So I'm not saying one on top of the other, but the severe forms, and I'm just bringing that up front, are very different. They may have a biochemical change that looks good, but the changes in the brain will not improve. So these patients in general tend to have failure to thrive, developmental delay, recurrent seizures, and metabolic acidosis. Their brain MRI can show cystic changes in the basal ganglia and the brainstem, the cerebellum, and then they can have hyperintensity in areas of the brain as well, and ventricular dilatation. So a lot of brain disease here. And MRIs can show elevated, again, lactate, similar to the other. These patients can have problems with glutamine-glutamate cycle abnormalities that's associated with the lack of continuous supply of oxaloacetate, because again, when you have a block, you can't make that step of pyruvate changing into oxaloacetate. So those are the patients, again, that can also have secondary hyperammonemia in some of the forms of these disorders. So there are three clinical phenotypes that are kind of recognized. There's a type A, infantile or North American form, and this is very severe. Most die in infancy and early childhood. There's a type B, which is called the severe neonatal form, which is the French form, and this is the type that's associated with hepatomegaly, changes in the brain, as well as abnormal movements, early death, and they have a biochemical phenotype that is distinguished from the others, can have hyperammonemia, can have changes in amino acids, and I'll talk about that. And then we have type C, which is the intermittent or relatively the milder form, which has normal mild delay in development and episodic metabolic acidosis during illness. Okay, so for pyruvate carboxylase deficiency, the type A, they have infantile onset to mild to moderate lactic acidemia with normal lactate to pyruvate ratio despite the acidemia. And again, why is it normal? Because both the lactate and the pyruvate are elevated. In type B, there's an increased lactate to pyruvate ratio more than 20, and that's important to remember. So that's the one that is the more severe type. They have increased acetoacetate to 3-hydroxybutyrate ratio. So again, a redox abnormality that's associated with abnormal oxidation in the liver, and that leads to basically ketones. So when you see a patient who has ketones with an elevated lactate to pyruvate ratio more than 20, and you're saying there's congenital lactic acidosis, so you have a high lactate. So compare pyruvate dehydrogenase to carboxylase. PDH, they're going to have a low lactate to pyruvate ratio, no ketones because they can't make them. And then this is the reverse. If you see it, you have, some evidence that it's more pyruvate carboxylase than dehydrogenase. In that case, would you give glucose or not? Depends on what you're seeing. So the other clue about this disorder, especially the French phenotype, is that if you do plasma amino acids on them, they have increased citrulline, proline, lysine, and then they have increased ammonia, and they have low glutamine. So this is, again, due to that glutamate abnormality that they show. For type C, they have episodic metabolic acidosis. They can have normal citrulline, and they can have elevated lysine and proline. And the main thing about these conditions, especially the type A and type C, is the lactate to pyruvate ratio is usually normal in PC deficiency, type A and type C. So it's less than 20. It's only in the one, which is the more severe one, type B, in the middle, that has a problem. Type A is very severe, but those patients, we don't see them that much. Amino acid concentrations in these patients, vary with the general metabolic conditions. So again, you can have high alanine because the lactate is elevated, and that's from the pyruvate. You can have increased citrulline and increased lysine, and that's due to the block in the urea cycle disorder secondary to a low aspartic acid. So again, pyruvate carboxylase and this relationship with the different urea cycle here, urea cycle liver metabolism. So the different pathways that are involved kind of determine the biochemical findings that you're going to see in these conditions. Low aspartic acid and glutamine as a result of the deficiency in the oxaloacetate and precursor. And then you can have ketonemia, and that's present in the French type of pyruvate carboxylase. And usually you can see here, if you check beta hydroxybutyrate, that it's elevated, and these patients, it's reflecting the low NADH to NAD ratio inside the mitochondria. So as I said, it's a oxidation reduction defect that is there. Another thing is these patients can have hypoglycemia because oxaloacetate, if it's not being formed, that limits gluconeogenesis. And it's very important that this hypoglycemia is not a consistent finding. So it's not always seen in all patients, but if you see it, you should know that they are allowed to have glucose. This is carboxylase, not the other one. And then hyperammonemia is associated with the urea cycle function disorder. So if you treat the primary condition, then you will have less of the hyperammonemia in these patients, and you can have some abnormalities in the CSF, as you see here. Molecular testing is the way to go when it comes to mutation testing. There's different types of mutations, and it's just important to remember that there are also cases where there was mosaicism, and the patients who have the homozygous pathogenic variants, especially with the type B, which is the French type, have the more severe disease. And there is genotype-phenotype correlation. That's what I just wanted to say. So the difference between PDH and pyruvate carboxylase is also genotype-phenotype correlation does not exist in PDH, but it is more common to see in pyruvate carboxylase. The treatments is alternative energy sources. So whether you say, I'm going to give anaplerotic-like compounds, so citrate, stuff like that, that will work, okay? But the point is, it might improve the biochemical changes, but it will not prevent the neurological manifestations for the more severe forms of the disease. Aspartic acid supplementation may help with the hyperammonemia because that's associated with the defect in the urea cycle. Triheptanoid has been used in some patients. The ones that had it with the severe disease did not do well, and it didn't help. The ones that have the milder forms, yes, it may have made some changes. Orthotopic liver transplantation has reversed the biochemical abnormalities again in 2 affected individuals, but again, if it's the severe form, it doesn't change what happens with the brain. And then I'm going to move to fructose metabolism. And fructose metabolism, there are 3 inborn errors that we need to be aware of. The main ones are the hereditary fructose intolerance, or HFI. which is right here due to the aldolase or fructose 1P aldolase deficiency. And then the other one that's common related to the gluconeogenesis pathway has many common features to GSD1 is fructose 1,6-bisphosphatase deficiency. And that would be fructose 6-phosphatase here deficiency. Okay, and again, I'm going to talk about them and where the defect happens and what happens, but I just want you to know that there's a third one that is considered benign. So there's fructosuria. So if you do reducing substances in the urine, you're going to see fructose, but it's actually a benign disorder, and that is essential fructosuria, where there's sugar in the urine, but it doesn't do anything otherwise, and that's due to fructokinase deficiency. So for HFI, the deficiency is in aldolase B. It splits F1P into the dihydroxyacetone phosphate, which is right here. Okay. Oops, sorry. And the effect happens in the liver, small intestine, and proximal renal tubules. So when you see that, you always have to think, okay, this is one of the conditions that are associated with renal tubular acidosis. So HFI is one of the conditions associated with renal tubular acidosis, metabolic conditions. These products that come out of the aldolase B are key intermediates in glycolysis and gluconeogenesis. So here's the problem is if you have fructose ingestion, that results in accumulation of F1P and then trapping of the phosphate, that's going to lead to a block in the glycogenolysis and the gluconeogenesis pathway, leading to, again, hypoglycemia in these patients and lactic acidosis through the glycolysis pathway being upregulated. So the lactic acid is going to come from whatever shunts into the glycolysis pathway. The main thing is to remember that this is all going to happen on exposure to fructose. So HFI is a condition that can be prevented by preventing fructose digestion. Depletion of the ATP leads to the increased production of uric acid, and the depletion is coming because you have reduced gluconeogenesis and reduced energy provided through that. So the depletion of the ATP can lead to uric acid elevation. You can have problems with magnesium, and you can have changes in the liver. The liver disease is very significant in these patients. They can have acute liver failure if the exposure is to a lot of fructose and they don't have the ability to break it down. So acute liver failure, that is reversible basically by holding the fructose in the diet. They also can have severe renal tubular acidosis associated with that, with loss of magnesium and calcium and all the products that we spoke about in Fanconi-Bickel syndrome. So just to let you know that IV fructose is toxic even in healthy adults. So we never use fructose on these patients to induce a challenge for them. That is unhealthy and unethical, and just don't do it. Some of the carriers, if they're exposed, so even the carriers, so some of the carriers, if they're exposed to fructose more than 50 grams, can develop hyperuricemia and gouty episodes with that. So that tells you how it is a challenge to even the carrier, not only the disease. For the disease, if you do that, they're going to go into acute liver failure. So patients will develop the symptoms when they're exposed to fructose or sucrose or sorbitol. So those are the products that you want to avoid. The patients will have vomiting, diarrhea, abdominal pain, hypoglycemia. They can have hepatomegaly. They can have the renal tubular acidosis. The lab findings, you can see, again, lactic acidosis, hyperuricemia, elevated transaminases from the liver dysfunction, INR abnormalities, all the acute synthetic dysfunction in the liver. Okay, so albumin is more of a chronic condition, so you might not see changes in the albumin, but you may. I mean, it's also an acute phase reactant, so it may be reduced because of that. You can see changes in alkaline phosphatase. If you check the urine, you can see reducing substances in the urine in these patients. And then the ultrasound can show hepatomegaly or an echogenic liver. And the diagnosis, you have to have a suspicion of it. And even in babies, they'll say, oh, this disease is one that happens when they're weaned because then they're exposed to fructose. So apparently some of the formulas contain fructose. So you have to be careful about these things and careful to what the family is doing exactly. I've known about it in families who they were giving prune juice and that's what induced it. So be careful, ask a lot in the history about these conditions, because again, they're treatable. And you can get them off the transplant list. If no mutation is found, despite there's a strong clinical nutritional history, then you can check for aldolase activity in a liver sample, but that's invasive. And then the other thing is the treatment, which is avoiding fructose, sucrose, and sorbitol in the diet. And the prognosis otherwise is excellent. A question that always comes up is, can I give those patients vaccinations and so forth? So if you read the information on the different types of vaccines, the authorities have been indicating that these patients should be kept in mind. You can look at each of the vaccines and make sure that the amount of fructose is minimal to cause any problems. But these are some of the things that are looked into in general. And I can tell you now, vaccinations are fine. What you want to be careful about is don't give it to them when you see elevations in the liver enzymes or something that's happening and they're unstable. So wait until they're healthy and then give them their vaccines if you need to do that, or when you need to do that, not if, when. And then remember that patients with HFI are at risk of iron deficiency and anemia. And the reason behind that is you're preventing them from getting, vitamin C, which is coming from fructose and fruits and stuff like that. So they can go into iron deficiency anemia very easily. So it's important to check their CBC, check their ferritin and iron studies, and supplement both iron and vitamin C, because they're not getting it from fruits. Immunizations are safe and give it when the patient is well and stable. And then the patients with HFI have abnormal isoelectric focusing of transferrin. So, when you see that result come out to you and they say, oh, this may be a CDG, a congenital disorder of glycosylation, think about, okay, that might be a sign that there's something in the liver, but usually the pattern is not exactly like the one in CDG. But keep that in mind, and these are reversible. So when you repeat the isoelectric focusing when they're under good metabolic control or out of crisis, you're not going to see that pattern anymore. Fructose 1,6-bisphosphatase deficiency, another one of the important enzymes, because it's a key limiting enzyme in gluconeogenesis, and its deficiency prevents formation of glucose from lactate, glycerol, and gluconeogenic amino acids as alanine. It's important to know that the dose or the amount of exposure is usually one that's tolerated more. So it depends on how high of amount of exposure they had. So small amounts don't cause a problem, but if you would give them, for example, an acute amount of fructose, so injection approximately 1 gram per kilogram, that can lead to a problem. Also, triggers as catabolism, fever, diarrhea, fasting can challenge them and lead to a metabolic decompensation. So clinically, when they're in decompensation, they're going to have hypoglycemia, lactic acidosis, hyperuricemia. So against GSD1, they have ketosis. GSD1 don't have are hypoketotic usually, but they also can have liver dysfunction that is very significant with the hepatomegaly. So again, different than GSD1. Usually GSD1 don't have liver dysfunction, but they may in the early stage before they're treated. These patients always will usually have liver dysfunction with them. And then the metabolic decompensation decreases with the age because the adults become more tolerant to the catabolic stressors. But you have to keep in mind that in pregnancy, it's a risk factor for decompensation, and you have to increase their glucose requirements in that case. The clinical signs are similar to GSD1 or the glucose 6-phosphatase deficiency, and neonatal hypoglycemia is a common presenting feature, and it's usually associated with metabolic acidosis and irritability and so forth. And the labs, as I've mentioned here, are important to look into. These patients also have triglycerides that are high, and this may be pseudo-hypertriglyceridemia because it represents glycerol elevation. So if you do a urine organic acid on these patients, they can actually have elevated glycerol. And when you do that, you always have to make sure that there's not any ointment or something that they've used for the baby on the buttocks to, for any rash or anything like that, because those can include glycerol as well. So if you see elevated glycerol and triglycerides are high and you have liver dysfunction, and this is a patient with lactic acidosis, and you're trying to put the picture together, remember fructose 1,6-bisphosphatase deficiency. Okay, and it's important in that case to do molecular enzyme confirmation. Prevention is the best way to do it, and you can treat these patients, for example, with IV glucose during acute episodes of illness, or if they're fasting for any procedures. Make sure that the amount of fructose, so they can tolerate some, but you want to make sure that it's less than 2 grams per kilogram per day, and prevent them from having single, like high dose exposures. And then practice Pearl's hypoglycemia in the neonatal period, especially in the first 4 days, resulting from deficient glycogen stores, consider it, as well as GSD1. And then pregnancy, it's important to make sure that during that time, their blood glucose is monitored. They can have uncooked cornstarch at night. And then it's important to maintain their glucose infusion during pregnancy, like if they're going to be delivering and they're in stress or they're not eating. And it's just to maintain euglycemia. So you don't want to put them on a high glucose infusion rate when they're pregnant, just simply to maintain normal glycemia. And then remember that increased glycerol in the urine organic acid can be associated with this condition, as well as glycerol kinase deficiency. So one, glycerol kinase deficiency is X-linked, remember that. But this one is an autosomal recessive condition. And remember that creams and oils used in the diaper area can also give you increased glycerol. So make sure that you tell them not to put anything on him when you're collecting the urine sample for that. And then HFI, the children have strong aversion to sweets and no teeth cavities, and then they have problems with chronic fructose ingestion, and they have renal tubular dysfunction, fructose B6 phosphatase. They usually do not have GI symptoms or failure to thrive related to chronic fructose ingestion. The problem is if you're giving them too much of it, and then they don't tend to develop RTA. And here you have in these patients the glycerol component and the hypertriglyceridemia that may be also explained by the glycerol. Then going through the galactose pathway, am I okay on time?
Yeah, you're right on.
Okay. So for galactose pathway disorders, classic galactosemia, of course, is the one that we're always worried about, and the one that comes up on the newborn screening that we're always attentive to. So that one is the galactose 1-phosphate uridyl transferase deficiency. And why am I saying that? Because there's other enzymes in the pathway that we need to be aware of. So if it's not that one, and we still see an increase in the newborn screen that is suspicious of galactose or a high risk of one of the others, then you have to know that you will need to test for the others. Because if GALT is normal, then it may be one of the other forms. So the other form is the uridine diphosphate galactose 4 epimerase, or GALE deficiency, and it exists in 2 forms. There's one that is more common, and it is usually the benign form, which is called also peripheral form, because it's in the RBC where the GALT is very low. But then after that, if you do for example, a liver biopsy, it's going to be normal in the liver. But then there's also a profound severe type, and that resembles the classic galactosemia, where you're going to have Gal1P elevation and so forth, and a risk for liver disease. And right now, I know that there are groups that are trying to look at the different mutations in GALE and try to predict phenotype, genotype, but this is something that is still growing with the newborn screening and identifying more of them. There's also galactokinase deficiency, and this is the form that usually happens because of galactokinase deficiency leading to galactitol being elevated and leading to lens cataracts. So this is another condition where the liver dysfunction does not happen, but these patients can develop early onset cataracts. So it should be in the differential diagnosis of early onset cataract. And then we have another condition that actually leads to galactose elevation, and that is GLUT2 or Fanconi-Bickel. So those patients, remember, they have a glucose galactose transporter defect. They can actually have an abnormal galactose and leading to an abnormal galactose on newborn screening. And I believe that there is also citrin deficiency can do that. So there are other conditions that may lead to an abnormal galactose on the newborn screen without being galactosemia. This is the pathway, just to remember where we are here. So we have problems in either GALT, which is the main or the one associated with classic galactosemia, which is the uridyl transferase. And with this condition, you have a problem where if you have a block of GALT, you're going to have accumulation of galactose 1 phosphate as well as accumulation of galactitol. And a reminder that galactitol is, the sugar alcohol here. So galactitol is the sugar alcohol of galactose, and that's what leads to the permeability abnormalities in the lens. For GALT, the GAL1P itself is associated with toxic manifestations in the liver, so that's actually what is thought to be involved in the pathogenesis, but there are other reasons as well. And then we have the GALE, which is right here, and GALE is also associated with problems with, again, either GAL1P elevation or galactitol elevation, or both of them elevated. The problem is, are you dealing with the RBC peripheral type, or are you dealing with the main type? So for classic galactosemia, whenever you consider a galactose disorder, just immediately, if you're not sure what's going on, stop the milk feeding first, and until you seek a diagnosis. And you want to seek a diagnosis as soon as you can, so that you don't prevent the mother, if she depends on breastfeeding or if she wants to do that, to continue to do that. So for classic galactosemia, the life-threatening complications will include feeding problems, failure to thrive, the liver failure, and the common thing for to remember is that E. coli sepsis in the untreated infants. So that's something that happens in these patients. Early lactose restriction as soon as possible, and it's important to have that happen during the first 10 days of life. And that can lead to, resolve of neonatal signs and prevent complications in the liver, sepsis, as well as neonatal death. And then the other thing is, if you treat these patients as soon as you can, there's still some elements where galactose is present in, certain things, whether it was the medication. So you have to look for, different places where galactose can be. But even when you do that, it seems that inherent to the metabolism itself, there remains problems, and these can lead to speech delays and specifically apraxia and motor abnormalities, even if they're controlled early from the start. And there's publications about classic galactosemia manifesting with premature ovarian insufficiency. So that is the more common type to have premature ovarian deficiency. There's African American variant that is not as common to cause it. And then you have to take into factor is that the mutation, if it's homozygous, and if there's a mean erythrocyte GAL1P that is greater than 3.5, and there are other breath tests and so forth, that would be associated more with the increase in the ovarian insufficiency phenotype. So there are some predictors of that, if I could say so. Newborn screening, you always want to make sure about GALT activity, because that's the one that carries with it the more burden on the liver disease and so forth. And you want to do that before you give any red blood cells. So if this is a baby that has a problem with anemia and is going to get red blood, transfusion, it's important to send the GAL1P and all the studies associated with GAL1P. I mean, galactitol is in the urine, so it's not a problem, but GAL1P is in the red blood cell. So that's why we're talking about sending these tests before giving packed red blood cells. The other thing is the standard of care in any newborn who is screen positive is immediate dietary restriction of galactose, but you have to know the circumstances. Again, read the whole newborn screening and look at what the state provides. So if it's galactose and they provide, for example, the GALT activity, and the GALT activity is remarkably reduced. And then you see that, you know, your state does the reflex, you know, variants that are common. So the common mutation, the SL135, I believe, I may be saying the number wrong, and the Duarte variant. So if they're giving you the three and they say one of them is abnormal, you immediately know that you're dealing with something really bad. If it's summer weather and the galactose is not that high on the newborn screen and GALT activity seems to be normal, or is the Duarte variant, you can be a little bit more comfortable about what you're dealing with and decide on, you know, how soon to put them on, you know, breastfeeding, or bring them in first and evaluate them first. I mean, you have some leadway there, but it's important to remember, look at the whole newborn screening and look at what information you have. And if you're unsure or you're worried, just stop the galactose for a limited period of time, explain that to the family, and tell them you need to continue the testing, and we'll, you know, decide after that comes back. Okay. And then it's important to remember that, you know, galactose can be present in different shapes and forms. Now, if the GALT1P is more than 10 and the GALT activity is less than 10% of control activity, that's likely the classic galactosemia or clinical variant until proved otherwise. And I said in the summer weather, if GALT is reduced, that sometimes might be an artifact. So you have to repeat the testing to make sure that you're dealing with it. In the meantime, if it's very reduced, I would still bring that child in if the galactose is elevated. And if you do GAL1P on the newborn screen and it's significantly elevated, again, just put them on the galactose-free diet. So these are the genotype-phenotype correlations with these disorders. So you can have the classic galactosemia, where these are the mutations. The most common one is the Q188R in the homozygous form. So that's the one that when you see it, there's no leadway there. You have to put the patient on the galactose diet. The same is for these other three changes. For clinical variant galactosemia, this is the SER135 to leucine. That's the one that's seen more in the African American, and it's milder than this, but still we do put them on galactose-free diet. And then you have the biochemical variant that's associated with the N314D, and that's the one that is associated with the biochemical variant, meaning you might see a reduction in the enzyme activity based on, you know, the Duarte variant. And when you have it with a mutation, you have to look at the whole picture to see, okay, if it's associated with a pathogenic mutation, and if there's a deletion there associated with the N, what are you going to do? So just talking a little bit more about looking into the different mutations and how to decide on, are you going to give them a period of trial with, for example, if you have a pathogenic mutation plus the Duarte, or if it's Duarte, you don't have to put them on a galactose restricted diet. But these things are very variable in terms of if you have a pathogenic plus a Duarte, are you going to try them for some time and then after that switch them? So it depends on the other tests that you have and your level of comfort and the families. Galactokinase deficiency is secondary to pathogenic variants in galactokinase, and those are cataract predominantly. They have increased galactose, and as I said, the sugar alcohol of galactose, which is galactitol. They usually will have normal GALT activity in GAL1P, so the liver is not involved. Epimerase deficiency, the galactosemia in these situations is associated with a GAL1P that's high, as well as galactose that is high, and then normal GALT. The severe systemic disease is associated with liver disease. The peripheral or benign restricted type, or RBC biochemical type, is one that's associated mainly with a benign form. There are some genotypes that are considered benign, and I'm hoping that these will be updated and upregulated. I'm not a galactosemia specialist, but there are people at Emory and so forth that are working on these things. So it's important always to go back to gene reviews and look at the papers to see if there are any updates when you find one that may have not been identified before as being benign. And then the galactose 1-phosphate uridyl transferase, that's secondary to pathogenic variants in GALT. Again, the classic galactosemia one is the one that's associated with absent or barely detectable activities in the erythrocyte and liver. And these are the GG and GN carriers. And then you have the clinical variant galactosemia, where there's 1 to 10% residual GALT enzyme activity in the erythrocytes or liver, or you have these biochemical variants that are associated with the G and D, which is the Duarte biochemical variant. Okay, for the Duarte variant galactosemia, as an example of the biochemical variant, you have to look about the configuration. So is it in, what's happening in cis and in trans? So if you have in cis configuration of the pathogenic missense variant, for example, and a GTCA deletion in the promoter region, that impairs the positive regulatory domain. And this is this mutation. If you have the Los Angeles variant that has, so that's the D1. So I'm sorry, I should have mentioned, this is the Duarte2, the one that has in cis that promoter region change. The Duarte 1 is the one also known as the Los Angeles variant that has the same asparagine mutation. So the protein mutation is the same. Same missense variant, but here it doesn't have that GTCA promoter deletion. Instead, it is in cis configuration with the mis variant, which is the leucine 218. Leucine, this variant does not cause galactosemia and is associated with anything with increased GALT activity. And we know that that Los Angeles one, we don't do anything. In fact, they have the higher levels of the GALT. So in biochemical variant galactosemia, you want to look at the erythrocyte Gal1P levels. And if you do, they're more than 1 milligram, but maybe as high as 35 when the individual is on a lactose-free diet, the level is usually less than 1. So what I'm trying to say here is if you are going to look at these patients for these variants and you're concerned about them, make sure first, if you're going to do mutation testing, to look at sequencing of the whole gene to see what's going on, and then try to identify, is it in cis or trans? That is if you're seeing that a mutation and you're concerned about it. If you see that it's the Los Angeles variant, that is one where, again, the enzyme activity is usually the GALT is high, so that's going to give it away from the beginning. And there are genotype, phenotype, in this case, associations that can help you and lead the way for you. And always when you're testing for galactosemia, when you are looking for levels, Gal1P and so forth, galactitol, it should be best done while they're not on the diet. So once the newborn screening, comes back and it looks abnormal, if the PCP calls you and says, what do I do next? I'm going to put the patient on a galactose-free diet. If they call you before they put the patient on the galactose-free diet, it would be good to tell them, draw these levels before you put them on the diet. If they already put them on the diet, still draw them when they come in to see what the effect is while they're on the diet. And then I'm going to go to the last group of disorders, which is the pentose phosphate pathway defects. So it's basically a group of disorders that happen in a pathway that is parallel to glycolysis, generating the NADPH, and to the 5 sugars, or the pentoses, and the ribose 5-phosphate. So it involves glucose oxidation in an anabolic rather than a catabolic way. So remember, when you have glycolysis, you have glucose oxidation ending in pyruvate in a catabolic way. In this case, it is in an anabolic way, okay? And then the importance is it generates precursors for nucleotide synthesis. So that's where the anabolic part, especially important for red blood cells and so forth. And then it has an oxidative role, which is irreversible, and it generates 2-NADPH. And that's used for fatty acid and cholesterol synthesis and for maintaining reduced glutathione inside of the red blood cells. Okay, and then it has a non-oxidative role, which is reversible, and that is that it generates intermediate molecules like ribose 5-phosphate, glycerol, aldehyde 3-phosphate, fructose 6-phosphate, which is again important for nucleotide synthesis and glycolysis. So despite this pathway, we don't do much about it, or I won't say that. I'm sure that you you do much about it when we have a patient that has a problem there, but we don't read much about it, but yet it's very, very important. And these are the different pathways based on, again, the oxidative role, the glucuronic role, the role in glycolysis, because that pentose phosphate pathway is connected to, the different pathways that are involved with the carbohydrate metabolism, including the glycolysis and the glucuronic acid pathway. So it is one that's associated with glucose oxidation that actually does not directly consume or produce ATP. So it does produce the NADPH. So just if you look at where, what is happening in the pathway, there is production of NADPH, and that's mainly for fatty acid and cholesterol synthesis. And then, as I've mentioned, it's also associated with fructose 6 and glycerol 3 phosphate production, which is important for glycolysis. So these are going to go into the glycolysis pathway. Glutathione, which is important again for oxidation reduction. So it prevents the oxidative damages to the cell. And then it's transported across to the glutamyl cycle, the gamma glutamyl cycle. And then you have generation of the ribose 5-phosphate for nucleotide biosynthesis, and that's important again for the nucleotide synthesis formation. And then when NADPH is low, that oxidative reactions of the pathway can be used to generate the ribose 5-phosphate. And then when NADPH is high, then you can use the reversible non-oxidative portion of the pathway to generate the 5-ribose phosphate from fructose 6-phosphate and glyceraldehyde 3-phosphate. Okay, this is just again a picture showing again where the production of NADPH is happening through the oxidative phase, and the production of the ribose 5-phosphate and then ribose 5-phosphate, which is important for the nucleotide synthesis, and the glyceraldehyde and so forth that is going to go into purine and pyrimidine metabolism, as well as the fructose 6-phosphate that is after that going to go into the glycolysis pathway, all that, and it's not taking away from the ATP. Okay, the importance of why we're looking at those pathways is there is a group of conditions that are associated with multi-system manifestations, and these are ones that were associated with a condition called transaldolase deficiency. And patients have had this condition where they have liver disease as well as endocrine function. It is a rare autosomal recessive condition, and it was described back in 2001. Prenatally, these patients have intrauterine growth retardation with oligohydramnios, and then in the neonatal period, they can have some dysmorphic features with cardiovascular defects and hepatosplenomegaly that appears in the neonatal period of time. So, think about why we're talking about this to raise awareness. Is some of these patients will have features that have cardiovascular defects, hepatosplenomegaly. The point is the ethnic background is more common in the Middle East. I mean, that's where the cases were initially discovered, mainly in Saudi Arabia, but there also have been cases that have been described in Asian background, European, Turkish, as well as other European and West African background. 81% of the parents were consanguineous, and in this paper, it was mainly because those patients, many of them came from the Middle East area. So just giving you an idea about that part. Where consanguinity among second and first cousins can occur. Characterization of the transaldolase phenotype, so the skin, and that's very, very important. These patients will have manifestations of cutis laxa or wrinkled skin, and these appear more in, as in the thin pigmented skin areas, as well as on the knuckles of the hands. They can have congenital heart disease, including VSDs, as well as coarctation of the aorta. They can have hepatic abnormalities, so we said liver dysfunction, but also they can have fibrosis and cirrhosis. And some of these patients actually get transplants. And they also can have splenomegaly. hematological features. So if you think of where the pathway is and the dependence of the red blood cells on the energy that's being produced by them. Again, the red blood cells don't have mitochondria, so they're getting their energy from glucose and these pathways. So you can have anemia. You can also have thrombocytopenia, renal manifestations, so they can have proximal and distal tubular dysfunction. So these disorders are multisystemic. They look like other conditions that we see, whether it was mitochondrial or CDGs, congenital disorders of glycosylation. Just keep them in mind, because if you go towards the others and you forget this one, which has a specific lab, I mean, you have to send for these 5 ribitol-related pathway abnormalities. There's specific labs for that, and I'm going to get to that part. You're going to miss them. So basically, they have multi-system manifestations. They have endocrine abnormalities associated as well, including genital abnormalities. And you can see here a table with the different disorders that they can have. And then at the end of the day, there is some supportive treatment. I mean, if you catch them early and you're able to diagnose them. And I keep on saying the 5 pathways. So it's the polyols, and the polyols in urine are important. So you do them in plasma or urine if it's offered in the urine. The most important thing is that you have to confirm it after that with DNA analysis and mutations, because sometimes the polyols, the distribution and the numbers are confusing. So it's very important, if you see an abnormal polyols urine or blood screen, that is very significant to confirm with DNA mutation, and you should send a test that covers that gene, the transaldolase. Just making sure that you have it there. Okay, and then in these patients, so what do the levels of these polyols look like? So the polyols, the erythritol, the ribitol, the arabitol. So you can see the ranges in the patients are kind of significant, but they're variable. And to be honest with you, if you don't see them too much, it's sometimes hard to make a decision. So if you do that, and then you confirm with genetic testing, that would be the best way to go. And I hope I completed in time. I'm happy to take any questions.
You did complete in time. Yeah, we've got about 10 minutes left, Rig. Thank you very much. That was a lot of ground that you covered, and having something as common as galactosemia and something as rare as Taldo in the same lecture is pretty great. So thank you very much. We have a question, Dr. Mosen.
Yes, thank you very much, Erich, for this very interesting and quite exhaustive talk. I just want to give an update on the GLUT1 deficiency. The gold standard now is not CSF study, but it's rather flow cytometry detecting the SLC2A transporters in red blood cells. And this quite done everywhere in Europe now. We are a little bit delayed in North America to do this very simple test and avoid lumbar puncture in these patients.
Yeah, and Mohsen, so it's Mohsen is your first name,
yeah,
right?
Yeah, it's Mohsen. You know me.
So,
yeah,
I know you very well. So Mohsen, thank you for bringing that up, because that is very, very important. So the reason why I did not describe it, because I know that it's Fanny Moschel in France.
Yes,
that does it. The problem is it's not in the US. So if we're depending on what we have here, then I just should have to say it still is dependent on the CSF at this point in time. But you are correct. There is a better test to do it. The problem is you have to send the sample to France to have it done. And yes, it's a specific lab, and the contact person, is Fanny Moschel, who's and there's another person who works in her lab, but that would be the right way to do the flow cytometry method.
Right, but you can also implement it very easily in your laboratory if they you have the automate the flow cytometer available. You can just buy the kit and contact the person who works in the lab of Fanny Michel. I can give you the contact, and you can implement it. It's very easy and cheap.
All right, sounds good. Thank you so much.
Thank you very much again.
I think I froze for a second. Any other questions for Dr. El Gharbawy? I don't see anything in the chat.
Yeah, I hope it was clear. Not that it was overwhelming. I really hope it was.
No, it was really good, Ari. Like I said, it's a lot of information to cover in one lecture, so you did great with it.
All right, sounds good.
Yeah, well, if nobody has any other questions, we can let out 6 minutes early. Everybody enjoy your weekend, and yeah, stay safe. See you next week. We'll talk about mitochondrial disorders with Dr. Falk. So thank you, Arig, very much.
Thank you.
Bye-bye.
Thank you. Bye.